by way of review, we had been talking about obviously portal hypertension and focusing on ways of managing complications of increased portal pressure. So we had mostly, let's go back a little bit. First, we did the diagnostic component where we were talking about how to do a transjugular liver biopsy correctly. Uh, so I'll just go back here. So we were reviewing this transjugular liver biopsy, the approach to doing so, when we would do that, um, and some of these considerations about catheter size and how to measure the pressures correctly. Then we were discussing tips for management of ascites and keeping in mind that can be from a lot of causes, so you got to make sure that it's the right thing to that you know that it's portal hypertensive ascites, and then additionally that patients have already failed medical management before you do the tips. So we showed some images there, and then this was just another tips, but without guidance. Um, Another tips where we used transplantic access, and I was actually talking to some of my residents yesterday about ways of visualizing the portal vein without using uh, well, all the different ways that you can use provide guidance for the portal vein passage, the needle passage during the tips. So I don't remember if we discussed this last time, so I'll just mention them quickly. So you can do the CO2 portogram like we have here. So you put a balloon up and inject CO2, and that shows you where the portal vein is so that it gives you a target when you're passing your needle from the hepatic vein into the portal vein. You can do the same thing, but with contrast. That's not ideal because when you're injecting contrast forcefully, it in theory can strip off the liver capsule, which I have not seen that. I stripped it a little bit with CO2 portogram. It was completely inconsequential, but that's the general teaching. CO2 is better than contrast for that because the contrast is viscous and so can cause damage. You can use an ultrasound from outside the body and watch the needle pass. You can use ultrasound from inside the body with intracardiac echo. You can use access through the spleen and put a wire through. You can access through the liver, put a wire through. You can access through the recanalized umbilical vein, put a wire through. Or you can access the artery and then inject contrast and let the contrast run all the way through from the arterial system into the venous system. So portal venous system. So there's a lot of different options for how to do it. And you often have to keep all of those in mind when you're doing any sort of tips access. And we talked about the RTOs and kept in mind the confusing terminology, but the fact that it's sort of all conceptually the same. We're closing the outflow in the setting of gastric varices specifically, not just esophageal. And excuse me, and that there's basically just a variety of different ways of doing it and some of the considerations for doing it both ways. Okay, so then back to I think this is about where we got. So that actually, I think, is most of our tips discussion done. So, but there's still other things that you can do in the setting of portal hypertension, including something I did yesterday, which we'll talk about in a little bit. But so when there are a variety of ways people can manifest bleeding from portal hypertension. The classic one is variceal bleeding in the esophagus or stomach, where they're coughing up blood, they're vomiting blood. But an alternative is bleeding from the rectum. So here's the case: 68-year-old guy, hepatitis C cirrhosis, had some encephalopathy. As we talked about, that's very common for basically everyone with portal hypertension has some degree of encephalopathy. But he had bright red blood per rectum. He was found to have endoscopically to have rectal varices. They banded them and ligated them, but he kept having bleeding, and so he IR was consulted for that. They actually placed a rectal Blakemore tube, which I've never seen before. But Blakemore tube is a tube that has a big balloon on it, and then you use that to tamponade bleeding esophageal and gastric varices. But you can apparently do it rectally as well to compress. But it's a temporary measure. You can't leave it up forever. In the esophagus, they don't like to leave it up for more than 24 hours because you get mucosal necrosis. So one of the options that we could have done is just place the tips. These varices are supplied by the superior and inferior mesenteric veins, so by branches of the mesenteric veins. So if you just decompress the entire portal system, that takes the pressure off the vessels, and the bleeding should stop. However, patient has, let's say, it was severe hepatic encephalopathy, so you don't really want to do that. You want to minimize the amount of shunting that you're creating. So instead, we went direct transhepatic here. So went into a portal vein and then went through down the portal vein retrograde into the SMV, which we're pacifying here. I don't remember what these catheters were here, but and then got down and injected contrast and pacified everything. And normally the blood flow is from the rectum cranially because the flow should be antegrade through the liver. But in this case, you inject contrast and it goes retrograde down to the rectum. And that tells you that there's significant portal hypertension there. It's reversal of flow. It's called hepatofugal flow. People like to use the term hepatofugal as opposed to hepatopedal flow, which is the correct or normal way. One of my attendings in residency used a mnemonic for that I still use, which is hepatofugal is futile. It's bad, basically. So that's when it's reversed. So anyway, we saw these varices. This is a slightly later part of the same run, and you see these big vessels supplying the rectum. And so what you can do is close off the vessels supplying these varices down in the pelvis, just above the rectum. And that way, and so here we basically drop some coils. Often you can use some gel foam or some sort of liquid embolic to get a little bit deeper as well. You don't want to go too deep though, because then you can take away all the venous outflow from the rectum, although it's pretty well collateralized. And basically, this is injecting contrast again after dropping the coils down here. Which can you see my mouse? I may be sharing this the wrong way. I hope I'm doing it okay. Well, anyway, can you see my mouse or no?
Yes, we can.
Oh, okay, okay, good. All right, we're all good then. So anyway, so yeah, you got these coils at the bottom here, and then yeah, and so this was injecting contrast, and there was complete stasis. And actually, you can see this. I think is the rectal Blakemore tube here on here. So anyway, so that's one way of treating it. It's a more localized way of treating it. So TIPS is sort of your big gun. I'm just going to take all the pressure off everything in the portal vein. This is a more targeted way of dealing with a less common but still, something we see problem. So this is a form of direct variceal embolization. So and I'm using the example of the rectal varices, but this applies to lots of different types of varices. So there's a variety of ways that you can get to these varices because they're for the most part they're all supplied by directly from the portal vein, inflow. There are some minor exceptions, but so if you wanted to get into the portal system, you can go through the tips that you already have. If a patient doesn't have a TIPS, like the patient we just talked about, you can do percutaneous transhepatic or transsplenic, or you can actually pretend like you're doing a TIPS. You can pass the needle go down from the IJ, pass the needle from the hepatic vein into the portal vein, and then do your embolization, and then just take the sheath out, take the everything out without leaving a tips. So you can either go through the tips, or you can act like you're placing a tips but just not leave one. You can, all right, so transhepatic, transplantic, and then if someone already has, they have a native shunt there that's decompressing the portal system, you can go through that. If you access in a vein somewhere, you can go backwards through that generally. So this is something you want to consider patients who are not great candidates for tips like we talked about, or if tips won't be successful. And that's so a common, not common, but probably one of the main reasons for that is because they have sinistral portal hypertension. So this is sinistral's left-sided portal hypertension, and that's where these varices are not in communication with the portal vein because of generally tumor or scarring or thrombosis of the splenic vein, things like that. And so that's uncommon, certainly less common, but because the communication is absent, the varices, the pressure from the varices does not come from the liver. It comes from um, the outflow, not a different location. So a TIPS is not going to help you generally. And so, yeah, as I said, this gives you access. You can do this for a lot of different types of varices: esophageal, gastric, peristomal, and rectal. Um, but Oh, and then anytime, but the thing to keep in mind is anytime you're closing one of these varices, you're increasing the portal pressure. Because we talk about varices like they're their own thing, but they're a form of portosystemic shunt. So they exist because they are decompressing the portal vein where the pressure is too high. So anytime you embolize these, the portal pressure is going to go up afterwards. So all the problems that you might do at TIPS to treat are uh, more likely to happen. So some patients will develop new ascites. They may get bleeding from varices, different varices. Other ones that are present but that weren't bleeding, well, now they are because the pressure's higher. You may get bleeding from the access site. That can happen, especially if you're going directly into the liver or spleen. So I think one of the main things to think about when you're thinking about portal hypertension is that everything's a balance. You want to get the portal pressure, or you want to decompress the portal system to the minimum amount possible that will take care of whatever complication you're trying to treat. The goal is not to get back to normal. The goal is to get just below whatever the pressure is that's causing problems. So again, for bleeding, it's 12 millimeters of mercury for esophageal varices, 12 millimeters of mercury. For ascites, it's roughly 8, although the data is not great for that. So just things to keep in mind. But that balance is pretty much central to everything. And so there are certain cases where you actually don't just want to decrease the portal pressure, you want to increase it. Increasing it when you're doing these direct variceal embolization, that's a secondary consequence. Sometimes that's the goal, and we'll talk about that very shortly. So there's another case. 45-year-old guy, colon cancer. He had a partial colectomy, so he has a colostomy in place, and they were bleeding peristomal varices. So this is another manifestation of a very similar thing to the last case, where you have bleeding rectal varices. Well, here it's sort of still, you can think of it as being rectal varices, but it's a artificial rectum. So the blood flow, instead of being reversed in the vein supplying the rectum, it's the reversed in the vein supplying the uh, the stoma. And so this was a CT. You see this large vein that normally would be draining the stoma, but actually the flow is backwards, so it's going out into the stoma. And so this is another case where you could do a TIPS, and I certainly have do a TIPS to decompress everything. But let's say you don't want to do a TIPS for one of the many reasons we've discussed. You could do what we did on the last one, where you go through the varix and close it from inside. You could do that. Same thing as the last case. Or you can do what we did here, and this is often what we'll start with, access the varix directly through the skin. So just stick a needle into it, inject some contrast to show that you're in the right place, and then you can sort of see, hopefully, the stoma is roughly here, this sort of radiopacity in the center. But we're injecting contrast into the dominant vein, and then you want to close the varix. And the hope is that this is the actual vessel that's bleeding. So you inject typically glue. So this is glue here. It looks just like contrast, but it's closing the varices that hopefully are bleeding. So um, so yes, that's what it looks like. So that's one option there. So that's another option. I mean, so yeah, embolization of peristomal varices. So this is a minority of patients because they have to have a stoma in order for this to happen. Um, this can happen when patients don't have portal hypertension, but that's not really relevant to our current discussion. And then we talked about how you can do other options. So draining the vein, well, basically treating, you can do the tips, you can um, do the treat the draining vein, and you can do both of those simultaneously if it's really needed. But keep in mind that when you're doing these sorts of things, you can damage the stoma because these veins are, I mean, you're embolizing parts of the stoma. So there is a risk that the stoma is destroyed. So it's always important to have surgery aware that you're going to do it. Okay. So 58-year-old guy, what is this for? Oh, okay, so this is a patient who has um bleeding esophageal varices, portal vein thrombus, and then he's found to have altered mental status, got better, but somehow was still referred for TIPS, apparently. Um, and portal vein thrombectomy, which I don't remember if we talked about portal vein thrombectomy, but so here, this is a coronal CT, and this is showing where the thrombus is or starting. So it's hard to see. The native splenic vein is open, and there's clot extending sort of subocclusively here into the SMV, and then the portal vein is out. But it looks relatively acute. So when transsplenic, because again, the splenic vein was open. So whenever the splenic vein is open, you know you have a decent shot of getting things reopened because it's that's the most common route to do it, to get access to the area of interest. So we see the flow here injected. This is where the portal vein is. That's completely thrombosed, and the flow is through these varices. Okay. All right. So then got into the SMV, injected contrast, and this is acute clot. You can still see the walls of the portal vein with this big filling defect in it. So basically, was able to, I don't think I have an image, but put up a target, like maybe it was a balloon or something in the portal vein there, and then got access through like you're doing a TIPS. Well, we are doing a TIPS, same thing. Um, and you can see this acute clot here, and then place the TIPS, and then did I not really? Oh yeah, so once we got so there's clot there obviously, and it's a Q clot. So we use ways to clean it out. You can use this device here called a cleaner, uh, appropriately named, and in this wire spins around, it's bent and it spins around and breaks up the clot, and the clot just goes out through to the lungs. And so that's one way. That's a big way to treat um, acute clot. You can also aspirate it using one of many aspiration devices. We often use Inari, but those are pretty sizable, so you need to have a tips in place to do it. So that's acute clot. Additionally, or acute portal vein thrombus. Additionally, we embolize the big varices here, and this is at the end you see good flow through the system here. Um, All right. This is a similar patient, but in this case, it's chronic. So here, this is what's left of the portal vein. All right, it's chronic portal vein thrombus. You get cavernous transformation. Cavernous transformation is where the main portal vein or where the main vessel is occluded. And so the vessels in the wall, the veins in the wall of the vessel dilate up and become essentially the main functioning pathway to get blood past the obstruction. But they're abnormal because they're not used to dealing with this level of pressure. So they're prone to bleeding and they don't reduce the pressure adequately. They don't get the pressure back down to normal. It's still elevated. So they're inadequate for doing that, but they're the best thing the body has to offer. Here's another picture. You can see the portal vein again is completely uh, occluded chronically with all these cavernous things. So if you're looking at a occluded portal vein and you don't know how long it's been occluded, you got to look for these little squiggly vessels all over the place. Those are the ones that tell you. And I would say conceptually, this is very similar to the acute. You get splenic access. You inject, and you see these little spidery veins. It's not that big globule like we saw in the last one. It's these little guys. And so ultimately, so you get, you give yourself some sort of target. This is important here. You can see in the top left of the image, these are normal looking portal veins, intrahepatic portal veins. These highest ones, these branches up top. And that's good. That means that you're in the right place and you know that there's still some native portal flow inside the liver, which is going to be important for this. So, uh, and you have to find the right outflow because, again, there's all these little vessels here that are functional but abnormal. You don't want to create a TIPS or recanalize the one of those vessels because, again, they're small and they're abnormal and they're not used to dilating up. So your goal is to find the true portal vein. And the indicator of that most commonly is if you see the left gastric vein coming off. Unfortunately, I don't have a great image of that, but the left gastric vein always comes from the main portal vein. So, uh, so that's once you see that, you're in the right place, and you're not going to see it if you're in some little abnormal decompressing vessel. And so then again, we find it and then essentially place a TIPS, embolize, one of the gastric or one of the varices, and so it looks much better at the end. So there are various classification systems for portal vein thrombus. It's the things thinking about are the time course, the percent of the occlusion, and then I guess response to treatment. Um, we have actually we're treating one today, but we have a whole workflow at Yale about how to approach portal vein thrombus. Generally, if it's relatively small and non-occlusive and acute, then you just have patients go on blood thinners. Sometimes that can be scary if they're have a history of variceal bleeding, but that's generally the first treatment, and often it will go away. You don't jump to doing an intervention just because there's spot in the portal vein. In fact, to try to avoid it. But once the whole portal vein is occluded, then I'm much more likely to want to go in there because if there's no flow, then the body can't really access the clot. If there's no flow through or past the clot, then the normal lytic mechanisms aren't going to work. And so then the problem is the longer that clot sits there, the more organized it gets, and the more likely you are to get that cavernous transformation. And opening an acutely occluded vessel is not that bad. Some challenges, but not that bad. Once it's chronic, you may not be able to offer anything anymore. So if there's complete occlusion of the portal vein or branches, that's when you really want to think, okay, I should intervene here relatively soon, like within a few days. All right. So I talked about the balance between too much flow and not enough flow when you're doing the portal venous interventions. We've mostly been dealing with closing or sorry, opening things or closing little abnormal vessels. Um, but here now we're talking about potentially intentionally increasing the portal pressure. So this is a patient, 52-year-old male, alcohol cirrhosis, who's had a lot of encephalopathy. Came back in again, and despite being compliant with meds, again, I think the most common reason for patients to have issues with encephalopathy is because they're not taking their meds. But this guy was taking it, and he had imaging done and showed some shunts. And I'll just note that when you're actually talking about hepatic encephalopathy, there actually is a grading system. It's a West Haven grading system, which is the actually developed at the VA right next to Yale, where we spend a lot of time. And basically, there's 4 grades and of increasing severity. I'll let you guys, you can look into it. But this actually came up on my board, so it's something to think about. Um, so here. This is a recanalized umbilical vein. So it's a strange picture, but it's a coronal view. So these are the these are the rectus abdomini muscles. This is the umbilicus right in the center. And there's this big tortuous vessel going around here that is a recanalized umbilical vein. So this is one of several portosystemic shunts that we often treat. And here's another one. So this is a big uh, shunt coming off of the superior mesenteric vein and draining into the IVC. So these are ways that develop because the portal pressure is too high and the blood is trying to find off ramps to get out of there. So um, so what can you do about that? So we can close them. So obviously that's going to have some consequences in terms of increasing portal pressure, but the hope is that you won't increase it too much, and so you'll just decrease the amount of shunting going from the portal system to the cable system, and thus reduce the severity of encephalopathy or the frequency of exacerbations. So here, what we did is accessed the umbilical vein. Actually did a very similar case yesterday, um, but access the umbilical vein, and you can see the flow is down. The liver obviously is like sort of central top right screen or top left screen, top right of the patient. And so when we inject, the flow is away from it because it's all reversed. And so then we went through. So this was getting into the umbilical vein, but the umbilical vein comes off of the left portal vein and then goes down to the main portal vein, and then you're in the portal venous system, and you can get other places from there. So we went through the umbilical vein, up, you can't see this well, but up through the left portal vein. So it's going here, all the way through the left portal vein, down um, through the main portal vein into the SMV, and then found these varices. And this is the other varix. This is the big one here that we got to by going through here. And then, oh, and this is a later image. So we're injecting from the portal vein. You see this big varix, and you can see it drains into the IVC here. So then you want to close it. And actually got a secondary access here. We're down in the IVC as well. But you can put a million coils in there to close it. And see here, this was injecting, and basically there's no flow. Actually, not only did we put these coils, we used a bunch of plugs too. These can be very difficult to close. They have a lot of flow through them. So we've shut that one down. and then so then retract everything. So this is the shunt that we closed, that retroperitoneal kind of shunt thing. And then now we're back in the recanalized umbilical vein. Okay, well, the umbilical vein here is another shunt. So we can close that too. And it's helpful because we have an access into the umbilical vein. So we're in a pressurized system. We've made a hole into it so patients could theoretically and have bled from this. So you want to close your access. You don't just pull everything out. So here actually got a second access, and but it's in the opposite direction. So we have crossing accesses, one down, one going like the one we used before, retrograde up towards the liver, and one going down away from the liver. And then put coils on both sides. So again, our axis is in the middle here. So we're closing the inflow and the outflow. And then this is gel foam slurry so we have the coils holding everything in there, and then we inject the gel foam slurry to reduce the risk of any bleeding and make sure everything is completely shut down, and then just pull the catheter out. And this guy felt much, much better the next day. The only thing was that he had some left upper quadrant pain, which lasted about a week. And that was from his portal pressure acutely increasing. So his splenic capsule was stretching. So that's interesting. That's something I hadn't seen before. All right, we're almost there, I think. This so okay, so this is a patient who had portal hypertension, underwent a TIPS, but then the TIPS, but then got issues with encephalopathy. So the last patient had issues with encephalopathy, but did not have a TIPS. This one does have encephalopathy. I'm sorry, does have a TIPS with encephalopathy. So the last one, the only thing we could do was close those big portosystemic shunts. And I should note that not everyone is going to have those sorts of shunts that you can close. Some of them you just say, I can't, I don't have anything to offer, unfortunately. Um, this guy has a TIPS, or this woman has a TIPS. So what you can do is reduce the shunting by changing the TIPS. So here you can see the TIPS is in place. It's widely patent. But we want to make it smaller. The way to do that, obviously making the TIPS bigger is easy. You put a balloon in, you dilate the balloon up, and that makes the TIPS bigger, easy. Reducing a TIPS is harder. There's a few different ways to do it, but the way I think most people do it now is putting two stents in parallel. It's really hard to see, but you can see we have two wires through the TIPS. We have there's two different stents here next to each other. This first one, where you can see the balloon here, that is an uncovered balloon, uncovered stent, a Palmaz Genesis. And you put that in there. You have that next to a second Viator, and you dilate the Palmaz, the uncovered stent, up first. Then you uncover the uh, the Viator. So you have two stents in parallel within the TIPS that you had before. And so now you haven't given up your balloon access to either of the two parallel stents. So you enlarge each one, generally just the Palmaz, but you're enlarging one stent to crush the other stent or make it smaller. So generally you enlarge the Palmaz to as it gets bigger, it makes the Viator inside the TIPS get smaller. And so what happens is you end up reducing the amount of flow through the TIPS. It's hard to see here, but you see there's sort of a wall here of non-opacification. And so that's because there is that stent, the uncovered stent, the smaller one, is sitting here pushing on this second Viator that's running through here. And so ultimately the flow is reduced because the lumen diameter is reduced. And you can measure your pressures and sort of determine if you're happy with your final gradient or not. So that's a little more complex, but that's one way of doing it. And let's see, it's hard to see here again, but there's a lot of metal here now. So there's the initial tips. There's sort of this is the end of the this I think it is of the second palm of the second Viator. And then there's the parallel one in here. Again, hard to see, but you end up with a lot of metal in there, and these are relatively prone to occluding over time. Um, and then it's not easy to reopen them. So
Sorry,
how do you
Dr.
manage?
Josh.
Sure, go ahead.
Sorry for interrupting you. Could you please? I didn't hear everything you said about the technique for reducing the diameter of the biator stent, the initial one.
Sure. So you already have the tips in place and you can't make the tips smaller. So what you can do instead is put a smaller tips through it, basically. So you have two accesses in the neck and two wires going through like we do here. And then you basically just put two stents in parallel inside of the tips that you already have. One of them you use a small uncovered stent, a balloon expandable stent. That's probably the most important thing, is a balloon expandable stent. And you put that next to another tip stent. And so you have your main tips that was there before, and you just leave that. But through it, you're putting another tip stent and with a balloon next to it. I'm sorry, with a balloon expandable stent next to it. And so you open your new tips inside of the existing tips, and then you expand the balloon expandable tips. I'm sorry, the balloon expandable stent next to it. And that compresses the new tip stent inside of the existing tips. So you have three different stents present. One is the old tips, one is the new tips stent, or endograft, and one is that balloon expandable stent. And two of those three are inside of the the prior tips that's too big. And then you can just measure the pressures and adjust how much the balloon is inflated and thus how small the tips is, the new tip stent. Does that make sense?
Yes, it does. Thank you.
Sure.
Um, though I'm wondering, in case you don't have a new biator stent, can you just use like two balloon expandable, maybe like a different covered stent and a balloon expandable stent, if it's staying
Yes.
within the whole?
As long as the new stent, the new like one that's going to function as the tip stent is covered. It has to be covered.
Oh, okay.
Yeah. Yeah. Because
All right.
otherwise
Thank
the
you very much.
flow will just go through the interstices. Okay. Yeah, it does not have to be. Usually just use the Viator because that's easy for us. But yeah, if you don't have one, you can do it that way. Okay. So we talked about briefly about encephalopathy. It's you had the West Haven grading system. The way to treat it initially is to ensure optimal medical management with lactulose and rifaximin. Most patients are on that. Patients will come in and with these exacerbations of encephalopathy, and the main reason is because they're not taking their meds. So you got to make sure that they're taking it. It can be unpleasant because the way that this manifests is bowel movements. So patients take it, they get bloating, they have to have a lot of bowel movements every day. It's unpleasant, but it helps keep their minds relatively clear. Um, so you can determine if they're taking an adequate amount by asking them how many bowel movements they're having. And generally, it's in the range of like three you want per day. And so if they're getting less than that, then you need to up the dose. Um, Ways of helping manage it that we can offer. that we already talked about. You can reduce an existing tips, like we just talked about. You can close a spontaneous portal systemic shunt, like we talked about, or in extreme cases, you can close the tips entirely. Um, when it comes to closing those spontaneous shunts, so not a tips, those big abnormal vessels, you they're they it's effective to do that, but it's temporary because the portal pressure is going to go up. And so that is going to try to find another way out. And some small vessels that maybe you couldn't see before are now going to take over as even as bigger vessels. Um, but the other thing you're doing, this comes back to that balance in portal pressure. So when you close these shunts, you're taking away an outflow, so the blood gets stuck in the portal vein, and you increase the pressure in the portal vein. And so there's an increased risk then of all the things that come from having portal hypertension, the big ones being risk of ascites and variceal bleeding. So patients have to know, I can help your mental status, at least temporarily, but I may make it more likely that you need paracentesis or that you have bleeding, which could be life threatening. One thing I don't have on here, but that is important is patients who have reversed portal vein flow. So again, the flow is going away from the liver out into these shunts. If you close these shunts, the flow in the portal vein doesn't have anywhere to go. And so you can get stasis. The blood just sits there, it's not moving. When blood is not moving, it clots. And so you can close these shunts. The blood has nowhere to go. It clots. Now the entire portal vein is occluded, and that's a problem. Not so much for the liver because the liver is already not using the portal vein in that case, but at least not in the traditional way. But then, patients then are at risk of cavernous transformation and all the complications that come from that. So just got to keep in mind, I want to reduce the outflow from the portal vein, but I don't want to take it all away. So there's a lot of these things to think about when you're doing these cases, and the consequences can be pretty severe if it's not handled appropriately. All right. So this is the last case, which is good because once again, I'm using all the time. This is a lengthy case. I actually published it, but this is to illustrate what else can you do if a patient has variceal bleeding, but you can't place the tips. So I'll just tell you, this is a guy, 67. He had a Whipple procedure for roughly 3 years ago, for what turned out to be a benign pancreatic lesion. So, and then he had some surgeries after that. So, that's all doing surgery close to the portal vein. He had a complication, which was his superior mesenteric vein was injured and it became occluded. His portal vein became occluded and it was all cavernous. So basically, his whole portal vein and his everything feeding his portal vein was occluded. So in this case, we don't have a splenic vein that we can work with, and we don't have a superior mesenteric vein that we can work with. He was getting intermittent GI bleeding, and so they were managing it endoscopically, but it wasn't working well. And he had what's known as ectopic varices. So we talk about esophageal varices, gastric varices, rectal varices. Ectopic varices is a term for any varices that are not in the typical locations that you see with portal hypertension. So in some cases, it's small bowel varices. You see it often in patients who have had some surgery because the portal pressure, like I mentioned a while ago, is not transmitted normally to the portal vein. There's been some break in the communication between the portal vein, between the liver, the portal vein liver, and where the bleeding is. The bleeding is upstream of some occlusion, and so you can decompress the portal vein, but that pressure change is not going back to the area that's bleeding. And so these can be very challenging to treat, especially, I mean, the anatomy is altered. It's just very difficult. So anyway, so he had this all done and he was having bleeding. So he had hemorrhagic shock. So this is when he was with us. He had hemorrhagic shock, you know, on death's door, not doing well. They did EGD. He had a variety of findings, but he was hypotensive. He had some small varices in his small bowel, but they couldn't tell exactly where he was bleeding from. And because of that, they couldn't really band anything. So he's actively bleeding. They can't find where he's bleeding from. Get a CT. These are all nice little videos. Can I control the videos? Yes. All right. So if you see, this is his portal vein, completely abnormal, basically all cavernous. And remember, this guy is actually not cirrhotic. This is all uh, due to the surgery, essentially. This portal vein looks terrible. The splenic vein is gone. His SMV minimal left. So there's really no way to decompress adequately. And this is another view of it, hopefully. Yeah. So again, you can see this portal vein. You see all these mesenteric vessels going into nothing. So it's a mess. So it's one of those times you may have to say, "Hey, I don't have anything to offer." Um, what we did here though is like, all right, he has some. I can try. I can put a tips in. Maybe that will help. I don't think it will, but we have no other option. So here we have both transhepatic and transsplenic access. Transhepatic access, luckily, there's relatively normal looking intrahepatic portal veins on the left side of the screen. On the right, we've gone into some little vessel being supplied by the spleen, but supplying the spleen. But you can see the outflow from the splenic vein, all this tortuous abnormal stuff. You can't do a huge amount with that. You can't really get through it. So that's a problem. But you say, okay, um, we looked this is another thing I mentioned you can inject through the artery to see what the to delineate the portal system once you wait for the contrast to go all the way through into it. And it's hard to tell. I wish I could pause this. Maybe I can. No, not well. Okay. So we inject it into the superior mesenteric vein. The contrast goes through the bowel and then into the SM. We inject it into the artery and then comes through the vein. And it's hard to tell, but here there's this abnormal remnant of the SM of the portal vein. It's not the portal vein. It's just some dilated collateral. So what you can do, we ended up putting a TIPS in. I wasn't sure it was the right thing to do. I measured a portal pressure. The gradient was only roughly 3 or 4, but the hope was, okay, maybe this will take some of the pressure head off. The main reason I did it though was so that if he had more bleeding, maybe I could work through the tips to try to find the vessel. Um, but ultimately that wasn't successful. So we placed this tips. Um, he got better, but he kept having slow bleeding. So we had to get transfused, every few days, and he couldn't get out of the hospital. They kept doing endoscopy. They couldn't find anything. So, but it was presumed to be in a small bowel. So after a long conversation, we're like, look, there is one other thing we can do. It's atypical. It's not common at all. And that's called a mesocaval shunt. A mesocaval shunt goes from the mesenteric veins into the IVC directly. Does not go through the liver. Does not go through a normal channel. So what I did, this is very hard to interpret, but there was go back. This is just showing the extent of what you can do with like no one. You probably never do anything like this in your life. That's fine. You may. I don't know. Um, Okay. This is the IVC here. This is some little remnant of the superior mesenteric vein. IVC, SMV. There's not much here. So you can bridge these two and decompress the superior mesenteric vein. So that's what we did. Connected these two. And so the way you do that, or at least the way I did this is the needle tip, this really echogenic thing here, in that little SMV remnant down here. Went straight through the abdomen. So this needle is through the abdomen in that little remnant. And here's injecting contrast, right? That little remnant, and this is all cavernous stuff going to the liver. The other thing is we have access in the IVC here. So yeah, so then we did it like a gun sight, 2 snares. The goal is to get the needle through both snare. One of them's in that SMV remnant, the other one's in the IVC. We tried to do this with ice, but it was not, couldn't see much. So we have a wire across there. We put the wire through the needle, you snare it out both ends, we have a wire across. And then you put a little balloon up to dilate the tract. And this is what it was. So now we've got from the IVC side all the way through into that remnant. Again, we're injecting, just showing that we're in the right place. And then this is with the stent in place. So now we're injecting the stent, and the flow is going from that remnant out into the IVC. So it's in the direction you want. It's not reversed anymore. We don't see those big ugly varices up by the liver, the cavernous transformation. Now it's all going the other direction. So we've in theory we've decompressed it. So we got this. There's some other stuff going on here. We're going to go into that. So there is the stent sitting between that SMV remnant and the IVC, decompressing things. And on just one last image, and I know we're running out of time again. This did take the whole time. There's that stent right in the center of the screen there, running between the two. And so that's actually my whole. So I'll just say he got better after that. His hemoglobin he stabilized. He didn't need any more transfusions. He was discharged. The stent occluded several months later, and no one told me about it. And so then he had more bleeding, not life threatening, but we tried to reopen it from inside the blood vessels. Couldn't really do it. He had a whole long saga where we went to another hospital where they tried for 7 hours and couldn't do it. Couldn't reopen it. I ended up reopening it by essentially repeating this process. I like passed the needle down through his abdomen, through the stent into his IVC, and then just relined the stent and got it open. And again, his hemoglobin, I think he was hovering right around 7. Now it's usually in the 9 or 10 range. I mean, he's not never going to be normal, but he's holding steady in a higher range and feels better. So, that's the sort of extreme stuff that you can get to. And the reason I like portal work is because it requires a lot of creativity, a lot of thought, and it's something where no other specialty really knows as much as we do about it, and can, other people. I could see a vascular surgeon one day learning how to do a tips, but I don't see them learning how to do this anytime soon. So it's an interesting area that's not well understood, and it's very IR specific. And we have 2 minutes left, so questions, if any. No questions. Okay. And it took me 2 full sessions to get through what I supposed to be a 1 session talk.
Thank you so much, Dr. Drew.
Sure. My pleasure.
This
Thanks
is
a
supposed
lot.
to be part of the Extreme IR.
It was, so yeah, I presented it at SIR a while ago and they liked it. So, but I'll probably never do anything like that again. I mean, it's the opportunities for these are very limited. So,
Thank you so much for
all
your
right.
time.
Of course. Thanks for coming.